Greetings and welcome to this installment of our review of the URAC Case Management Accreditation Program version 7.0, relatively new to us as we're recording this video. Today we're going to focus on the case management program, but specifically for workers' compensation case management organizations. I'm joined today by Sue DeMarino, who's Integral Healthcare Solutions Chief Clinical Officer. I'm Tom Goddard. I'm the Chief Executive Officer. Sue, welcome. Thank you for joining me today about this workers' comp case management program discussion.
Thank you, Tom, for inviting me.
Let's dive right on in and talk about program development, how the workers' comp case management program develops its program and what has to be in that program.
Sure. Well, the program development requires that you have a program description, and that program description needs to include things like your goals and objectives of your program. What is the scope of your services and those activities related to the scope of the services? So in this instance, we're talking about workers' comp. So you may want to speak to whether Voc Rehab is part of the services that you're offering, as an example. You have to identify those referral guidelines or criteria, like who can make a referral to you. Can an injured worker self-refer? Does it have to come from an employer that you're contracted with? And then what criteria do you have in place that govern the case manager caseload? Is it based on acuity? Does it base on a mix of both catastrophic and non-catastrophic cases?
And I can imagine that piece of the program description is also intended to serve as a tool for management to figure out if they have sufficient staffing. Would you say that's fair?
I would say that was absolutely spot on.
Got it.
And then you have to evaluate what you're going to base your program on. And there's a requirement that you use evidence-based and/or state-specific treatment guidelines. Oftentimes, the regulators will guide specifically what your program needs to look like. I will tell you, if the regulatory requirement is tighter than the URAC requirement, URAC holds you to whichever is tighter of the two. That's an important concept to understand. So again, if those jurisdictional requirements conflict with the URAC standards, the organization must follow the more stringent requirement.
And that's just a specific application of a general rule across, not only across these standards, but across all of URAC. If there are two sets of standards, URACs and state regulators, it's the more, or even clients, it's the more rigorous of those standards for the organization that must be complied with. So this is just a specific to this piece of it.
Yes, absolutely. And then you're going to identify the clinical decision support tools that you're using. You're going to talk about having a personalized case management plan. Oftentimes, though, you have in workers' comp, if the patient is represented and there's attorneys involved, they may not be permitted to talk to you. And then that's something you have to make a note of. That's something you need to address in your program description, how you're going to handle it. Because remember, URAC's definition of case management includes that it must be member-centric. They have to be involved in the process. So instead of doing case management, you may be doing behind-the-scenes care management. And how do you differentiate those two? You need to speak to care coordination principles that you're going to use. You have to include information on a return to work assessment. Who does it? When is it done? And then any transition of care that may be within the scope of the services that you're provided. What happens if it's an unexpected transition of care? How are you helping that injured worker get to that next level? And then what criteria are you going to use to discharge that injured worker from case management? So you have to have clearly defined criteria.
You also have to define performance measurements, do you not, in these
Part of it.
stages?
Yeah, we're going to talk about that. Yep.
Okay, sorry about that. Yeah,
It's
please go
okay.
ahead.
And then you also have to define those performance measures, as you led me into, Tom. Thank you. And the roles and responsibilities of the committee. What are they supposed to do? What are they responsible for? You have to identify your program staffing requirements. You mentioned a few minutes ago, Tom, about the
The
criteria
caseload.
caseload. Yes. Again, to your point, that will help define that program staffing requirements. Reassessment timeframes, we talked about that. We'll be talking about that in a few minutes related to the care plan and the assessment, doing those reassessment at specific intervals. And then what type of program reporting are you going to have? Some of that may be governed by the regulatory body. And then this program description must be reviewed and approved by leadership at least annually. And as you may or may not know, URAC has a definition of annual, and we want to make sure that you are getting the benefit of that definition. So URAC defines annual as month year to month year, plus or minus a month, and or to the quarter. My recommendation is always to the quarter. I think that gives you a little more flexibility. And so that would be my recommendation. But then your policy needs to define what annual means to you.
And whatever you do, right, you've got to follow whatever your policy says, even if you've chosen one of the more lax approaches in terms of defining annual. Whatever your policy said then becomes the law. And if you violate that, you're violating an entirely different standard.
And the other thing you need to consider is that injured worker or claimant may have limited rights, and that other stakeholders may impact your decision-making. So you need to take that into consideration. Those other stakeholders might be third-party administrators, adjusters, attorneys. As I said, if you're not permitted to interact with that attorney, that may impact how you do whether you do case management or care management.
Got it. Got it. So if I'm counting right, there are about 18 different components to this workers' comp case management program description, including the return to work assessment. URAC, as I understand it, and correct me if I'm wrong, Sue, will look for all 18. Their tool is when they're checking off whether you've got it in one big document or various little documents, to make sure that every one of these 18 items required by the standards are in your program description. Is it? And they're enforcing that pretty rigorously, are they not?
That is correct, Tom. You need to address it.
They've got a checklist, so you need a checklist.
Exactly.
Got it. All righty. So let's move on to monitoring and evaluation.
So there has to be documented monitoring and evaluation at least annually of how your program is doing. What does that perform? What has your performance shown in the last year? Did you need to put in place any corrective action plans? Or based on the evaluation that you're doing, do you need corrective action plans? You have to, again, evaluate what evidence-based or state-specific guidelines you're going to use within that program. So you need to take that into consideration as you're monitoring and evaluating that program. And then again, that case manager caseload. So again, thinking about metrics that you might put in place or performance indicators that you might put in place that will help you meet the intent of doing this monitoring and evaluation.
I see something in the standards here about screening criteria. That also applies to the workers' comp?
Yes. They have to have screening criteria. Absolutely. They have to define.
Well, and they have to review as a part of their annual review of the effectiveness of the program, whether these screening criteria work. How is that done typically?
The evaluation of the screening criteria,
Yeah.
in some jurisdictions, you are not required to put the referral reason, but in areas where you have that information, that is what you're evaluating. You can also look at what percentage of patients actually opt in to the case management process. And that might be an indication of your screening. If your number is too low, you may need to reevaluate your screening information.
Got it. Right.
The next section deals with reporting and analysis of your performance metrics. So again, you need to analyze the data and report the outcomes to your leadership. And it needs to include timeliness of workers' comp case management services, case management caseload, what percentage of your claimants have or injured workers have returned to work, and then the satisfaction of those injured workers, family members, caregivers with the services that you have provided. This can be a standalone report, or you can do it as part of your QM program evaluation, but addressing it that it's covering case management.
And so long as it's reported to leadership, that's an important key to this standard. Yep. Yeah. Got it.
Absolutely. And you may have leadership on your quality committee that it might be a little easier to get an audience with them, depending on the levels of separation between those that write the report and lead the department and the leadership team.
Right. Got it. All right. Well, let's move on to screening and assessment.
Okay. So again, in workers' comp, case management consent is often presumed, and you may not have to obtain a consent, but you need to state that in your policy and procedure. If the jurisdiction does not presume consent for of case management, then you have to document the consent.
Does this vary widely from state to state in your experience, Sue?
I would say it can, but typically URAC gets a lot of Ohio BWC case management organizations, or the MCOs, and their consent is presumed. So it just depends on where you're at in the country.
Got it.
And then you need to document the referral source for the workers' comp case management services, part of that screening process.
Got it. Got it. And so that's the screening. And so how about the assessment piece of these standards?
I do have one other point to make, though, that I failed to mention earlier to you, Tom, when we were prepping. And that is that some state workers' comp laws requires you to participate in case management. And if they fail to, they may not receive services. They may not get reimbursed for the services that related to the injury that they received at work. So I just wanted to make that point to make sure that organizations address whether that's the case in their program description.
Right. And so that may not be in the URAC standards, but it's certainly a legal requirement in certain states, from what I understand.
Yep.
You saying. Got it. All right. Now moving on to assessment.
Okay. Again, so now we're going to talk about whether the injured worker, how do they, are they involved in the process of case management? And then how do they identify themselves? Like, or do they consider this a burden? Do they consider it, their right? Again, thinking about their mindset there. And then collecting information from multiple sources. You need to identify where you're getting the information. Are you getting it from the injured worker? Are you getting it from their family, their providers, from the facility, or other members of the healthcare team? You may be getting it from clinical records, the physician's treatment plan, if it's available to you. And you have to review information in accordance with, again, those regulatory requirements, policy requirements. And I can remember when I first started doing workers' comp case management, I was looking at a policy a URAC applicant sent in, and they kept talking about a Freud, and I kept scratching my head thinking, oh, what could this possibly mean? And then when I realized it, I've never forgotten it. So it's the first report of injury or illness.
Okay.
So you'll hear me talk about Freud's now because I feel like I know a little bit about the lingo.
You're a Freud expert. Got it.
Yeah, I'm a Freud expert.
Well,
Yes.
that's a pretty narrow niche, Sue.
I know, right? Exactly. And then the injured worker's perception of what their healthcare needs are. So how are they addressing, how do they feel about what they need? And then you need to also review the claims and administrative data. And then if you have access to the functional capacity evaluation that's often done in workers' comp, do you have access to that? That should be reviewed. You should be looking at a job analysis and a job description if it's available to see what work they need to do and are they capable of doing that work. Like if they have to do a lot of lifting and they've had an injury to their arm or their muscle area related to lifting, that they may not be able to do that job at the current time. And then you may or may not be familiar with independent medical evals, their IMEs. So if that's available for you, then you would take that into consideration and review that information. And then oftentimes the customer will provide instructions to you, or there'll be account guidelines that you need to take into consideration.
Ideally, though, it sounds like this information not only can but should come from multiple sources. So you're kind of getting it from all of these sources, so you have a full, well-rounded picture of the situation, both with the worker and the setting that they're hoping to return to as a worker.
Great summarization. Thank you, Tom.
You bet.
So you need to use a standardized tool. You have to evaluate the history of their present injury or their disability. You have to also take into consideration any medical, cognitive, behavioral health issues, because that may impact the ability of the injured worker to recover from whatever the injury or illness is. Whether there's a substance use disorder, vocational, if they no longer can do the same job, they may need vocational assistance, functional and social determinants of health. Oftentimes I speak to looking at social determinants of health like almost immediately, because that may impact the ability of the injured worker to even be able to comprehend what you're talking about. So for instance, if someone is now homeless and they're not going to be able to hear what you're saying because they're going to be so worried about finding a place to be safe. And then the assessment process should include the involvement of the injured worker and maybe the family or other caregivers as needed. Any available resources that may be needed. Does the injured worker have provider options? Sometimes that's regulated by the state on what providers they can go to. And then do they have access to those services? And then you will need to do an initial and then a subsequent reassessment as required by that the plan of care that you're going to put in place.
Got it.
And then one new requirement that I smile at is it's a leading indicator, an optional standard that says that you assess the injured worker's ability to engage with digital health resources and services. I would like to say that that's a given in today's day and age, but sadly, I do not believe that to be the truth. Would you agree, Tom?
It is certainly not universally the truth, and which is why it surprises me a bit that this is only a leading indicator. I would, if I were king of URAC, I'd probably say, no, we need to know, because if we assume that everybody knows, everybody has moved into the 21st century, we're liable to leave a worker out of this process. So, so we better assess this just because URAC is required. So. All right.
Let's go on to the medication review, assessment, and interventions. I have often said that this area, along with the assessment area, is usually the reason why an organization is unsuccessful in either obtaining or maintaining their URAC accreditation.
I'll say when I first started doing case management reviews before you joined us, I remember being very impressed with how central the assessment, the medication assessment piece of this was. So let's flesh that out a bit for our viewers.
Okay. Well, one of the things you're going to do on the initial and any other reassessments that you do, you're going to determine whether you need to put goals in that plan of care related to that medication safety or medication management. So what do you need to evaluate? Well, you need to understand, you need to evaluate whether the injured worker understands the meds they're on. And that includes those opioids, biologics. It also might include over-the-counter herbal meds. You need to evaluate adherence. Are they taking their meds? Do they have any allergies? Are they having any side effects? That would all be part of that medication assessment. Do they have a history of a substance use disorder? Oftentimes when there are injuries, they are prescribing opioids. And you want to make sure that someone with a substance use disorder, that the provider is aware. You want to make sure the injured worker has access to a current med list, including those vitamins and herbal supplements. And do they share that med list with all their providers? So they may have a PCP, but they may also have 3 or 4 specialists. And if they're getting medications from all, they should be sharing that med list to prevent duplicative therapy or contraindications.
It's always struck me that this is one of the central values of case management is to help pull together a variety of case management of the providers involved in the management of a injured worker's health, because they're not necessarily doing that. This special, and not even the PCP is necessarily doing that, right?
Right. You need to evaluate whether medication reconciliation is needed. So if they don't understand their meds, they're having side effects, they have duplicative therapy or cumulative, where adverse events could be happen because they're on, a couple of different opioids and other meds that may impair ability to function. So maybe a med reconciliation needs done. That doesn't mean the case manager needs to do the med reconciliation, but at the very least, they should be making a referral to either a pharmacist, back to the attending or another clinician, looking at what resources your organization has for medication reconciliation. And then whether there's a medication therapy management services are needed. So again, part of that medication review assessment, need for MTM services, need for med reconciliations. And then you need to be able to support interventions to include medication access. Can they get the medications? Can they get them safely? Are they adherent to therapy? If they're not adherent to therapy, what type of education will you do to help them become adherent? Take the medication with an activity of daily living. Take it on days where they have routines, having alarms on. We all have smartphones today, or most of us do. You can put timers into and reminders to take your medications. And then is the injured worker independent in their medication management? So how are you going to help support that independence? And then another intervention might be that the injured worker collaborate with a pharmacist, and then making those referrals for those medication-related services, which we mentioned before, med reconciliation and MTM services. If you are governed by a regulatory body, they may have MTM services contracted. They may have folks that will do med reconciliations. You can refer them back to the pharmacist who did a fill at their local pharmacy. Okay. So one thing I want to just tell you a little bit about, And that is if at close of case, if URAC finds during the file review that you have a section, like a category, an assessment category that's never been addressed, even if you just document that it was not relevant to the case and why, URAC, if it's never addressed and you have no documentation, URAC would consider that case not met. Same
Right.
way.
So this is kind of the push me, pull you thing. Sometimes the assessment has so much, it's hard to do in one thing. So you might postpone it, but you got to make sure you've got a system so that you don't postpone it indefinitely so that it never gets done. That sounds like a really important thing that you've just raised. Thank you.
Sure. And it may be that the whole assessment is deferred. And if there's no follow-up, like the injured worker might say, I have a doctor's appointment, this is not a good time. And if there's no follow-up documented that you tried to complete that assessment, URAC will mark it as not met.
Got it.
Okay, or non-compliant.
All right. Well, let's move on to the case management plan development piece and the member case management plan. Let's talk about that a bit.
Okay, so you have to have an individualized case management plan. There has to be collaboration with the injured worker, and maybe the injured worker is not available. And so you collaborate then with family, caregivers. You might even have to go out to other stakeholders that are part of the multidisciplinary care team. And you have to address some very specific things. You have to document any disagreement or non-participation by the injured worker and the actions that are being placed in that plan of care. And then, interventions based on the treatment plan need to include input from that injured worker. So they have to be they have to collaborate on that plan of care. Okay. And you're going to talk about medication management, desired outcomes for allowed conditions, in addition to short and long-term goals that are measurable. What do I mean by measure? There has to be a number, a ratio, a percentage tied to it, or a distance. If you're using a scale for pain, what was the baseline? Did the patient start out at pain with 10 being the worst and he's at 10 and you want it to come down to 3 within a certain period of time? That's what makes it measurable. If they're unable to walk, if they're walking 5 feet now, where do you want them to get to? Is it 15 feet in a week or a month? And then what health education and information do you need to help provide to this injured worker so that you can promote informed decision making, that the injured worker has some input into the plan of care. Studies have shown that if you have injured worker or member involvement in a plan of care, you're more likely to achieve the goals because they have input into it. They feel like they have a piece of the pie, basically. And then what is their progress to return to work? Because at the end of the day, I'm betting that your long-term goal is either same job, same employer, different, same job, different employer, or different job, same employer, along those lines. That's usually the long-time goal, always, is returning to work. And then the short-term goals are the steps that will get you there. And then the plan to further communicate on that plan of care to get updates from that injured worker and the frequency, and how does the injured worker want to receive that communication? Do they want you to call them? Do they want email? Do they want you to use texting? And does your organization then require consent for the texting and the email communications?
I
And
would
always,
imagine that this is not unlike the whole you've got to follow your policy requirement we talked about earlier. You really have to follow your plan requirements. So if you and the injured worker agree that you'll communicate every month by email, the documentation for that case better demonstrate that you communicated to that injured worker by email. Is that how you're actually interpreting that?
There has to be the communication. I mean, you can identify, I don't think on every note you have to say it was an email, but you have to have documentation of that communication, that you communicated with this injured worker and this was discussed and this was what was agreed.
And at the frequency that you all agreed on it.
Exactly.
As documented in the plan. Got it. Got it.
And if you can't meet the frequency, what's the barrier to meeting that frequency turnaround time?
Good point. Good point.
And then again, when you're building the plan of care, and I'm betting that you may have some templates for your plans of care given very specific injuries, and make sure that you're using evidence-based guidelines and any state-specific treatment guidelines to help build those plans of care. Okay.
All righty. And then I would think the next piece of this, of course, if I'm reading the standards right, is monitoring the progress through that plan.
So you're going to do ongoing review and assessment of those goals against that injured worker's progress. You're going to look at ongoing collaboration, communications with that injured worker. You're going to make revisions to the care plan as things change. The goals that you may have set after the initial assessment may change altogether depending on how the injured worker is doing. You may have to come up with a whole new set of, prioritize a whole new set of goals and the associated interventions. And then you need to plan for transitions of care and what information you're going to provide to that injured worker.
Right, right. Well, I think we're in the home stretch here. We're going to close out this conversation today with, appropriately enough, the closure of the case. So take it away, Sue, about how to close a case and what the Workers' Comp Case Management Organization needs to do around case closure.
Okay, so you have to, again, you need to have criteria for when you close the case. And some of that may be regulatorily directed to you. It may be contracted language. It may be an organization decision. So whatever that closure criteria is, the case manager needs to be evaluating the injured worker's progress toward that, whether they're close to meeting those closure criteria. But now that, let's say that they have, so then what do you need to document in the records related to that case closure? Well, you have to document their return to work status. Did they reach their goals? Did they get to the outcomes that you had set for them, or that you expected to happen with the interventions and the goals that you put in place? And then do they need any further referrals? Do they need any community support? Do they need behavioral health, social service? So then that would need to be documented. And then, of course, what that rationale was for closure. And then was there any barriers at closure that related to the closure of the case management services? So what was that resolution of barriers, and what were the concerns that were raised, and how did you resolve them?
And then, of course, the injured worker needs to know about the closure and needs to know something about the closure. So let's talk very briefly about the communication of the closure to the injured worker. So again, you'll have to look at the stakeholders. In workers' comp case management, they always talk about the 3-point contact, and that includes contacting the injured worker, the employer, and the provider. And so you may need to notify all of these stakeholders regarding the closure. And that notification can be verbally, it can be in writing. And then if it's applicable to the closing of the case, are there any post-closure referrals that will be needed? How would they access that referral information? What resources might be needed post-closing the case? And any potential plans for transition of care. Thank you, Sue. I think we've covered it. So folks, if you're watching this and you have any questions about, well, how do I actually document this? Or what's the process for modifying my policies and procedures to get moved from version 6.0 to 7.0, or if you're a first-time applicant for accreditation, all of this is new to you. If you have any questions of this sort or of any sort about case management or accreditation, please reach out to us with the information that we've provided along with this video. And in any event, I hope you all have an excellent day. Thank you. And thank you, Sue.
Thank you, Tom.